In this video, I will not discuss the pneumonic type adenocarcinoma in details, but I will talk here about one point regarding the diagnosis of invasive mucinous adenocarcinoma. Although of features that can be in favor of diagnosis invasive mucinous adenocarcinoma in HRCT, like the findings in the consolidation itself, there will be can be a stretched or irregular air bronchogram manifested by dilatation, rigidity, or narrowing, or presence of air bubbles or lucency within the consolidation, adjacent ground glass opacities to the area of consolidation, presence of low density areas within the consolidation, CT angiogram sign, or cavitation. Although these criteria that can suggest presence of invasive mucinous adenocarcinoma within the consolidation itself, or even there is another features also can be helpful as bulging of the interlobar fissure. Major or minor fissure can be bulging because of presence of the pneumonic mucinous adenocarcinoma, presence of centrilobar nodules on subsolids adjacent to the pneumonia. These features, although they are in favor of the diagnosis of invasive mucinous adenocarcinoma, the patient will be managed as infectious pneumonia by the clinician. And in clinical practice, invasive mucinous adenocarcinoma is considered when the management of the infectious pneumonia failed. In other words, in unresolving pneumonia. So here, even with the best efforts by radiologists to suggest the invasive mucinous adenocarcinoma in pneumonic type, it will not be considered as a priority for the clinician. But we have two situations that the radiologist should insist and report that this case should be managed as invasive mucinous adenocarcinoma. Here, one of the situations, we have left upper lobar consolidation with adjacent or ipsilateral interlobular septal thickening. Infectious pneumonia cannot produce this finding. Here, radiologists should be confident to diagnose left upper lobe pneumonic type invasive mucinous adenocarcinoma with ipsilateral upper and lower lobar interlobular septal thickening, whatever smooth or nodular, denoting lymphangitis carcinomatosis. So here the radiologist will do his part for early diagnosis of the patient or early diagnosis from the point of radiology. But this patient is metastatic and it's a stage 4. The other situation, when you have here, like here, left lower lobe pneumonic type adenocarcinoma with pleural effusion, both lungs shows randomly distributed nodules denoting metastasis. Here, it's important to differentiate between the types of distribution. Centrilobular should be oriented well, that nodules are not present along the fissures or costal margins, and not perilymphatic distribution, which is following the interstitium of bronchovascular interstitium, interlobular interstitium, and subpleural interstitium. Presence of the nodules here along the pleura and along the pleural surface will exclude centrilobular nodules. Now we have to differentiate between the perilymphatic distribution and randomly distribution. And here, as you see, the nodules are randomly distributed all over both lungs, not following the interstitium or bronchovascular or interlobular interstitium. Here, the radiologist is confident to diagnose metastatic invasive mucinous adenocarcinoma, and infectious pneumonia shouldn't be considered in this situation. In case of centrilobar nodules and tree bud in the presence of left lower lobe, this will be a characteristic for infectious pneumonia like tuberculosis. But here, the nodules are randomly distributed. So this is indication for metastatic invasive mucinous adenocarcinoma, and thanks for your attention.